All right, so we're live. So this morning's discussion will focus on the film Poltergeist. So um, leave it up to the group. Any particular character you'd like to start with? There's no wrong answer here. Carol Ann. Okay, so I mean, from a non-medical or a non-clinical perspective. So try to lose the white coat for a second. What did you see that was interesting to you?
Girl, like playing around. She was interested in a lot of things, very sweet.
Mm-hmm.
I don't know.
Let's say she came to you as her cousin and told you everything that you also learned through watching the film. Your reaction?
To her, like, talking to the TV and that kind of stuff.
Everything you know of Carol Ann.
A little strange then. Definitely a little weird. Talking to the TV, one thing, and kind of following, I guess, the friend that she was making in the TV. I guess, like, if it wasn't from, I would kind of think it was like imaginary friends that she was seeing if it wasn't like the poltergeist,
Right. So, I mean, this is where I think as a clinician now, we would want more collateral information. What are other members of the family experiencing? What are they witnessing? Because if it's none of the above, this may be an imaginary friend. Okay. I don't know her exact age. Do we know her age?
She said 5.
5. Well within reason, 5-year-old to have an imaginary friend. So I hope when you have children, your nieces, your nephews, they tell you a Carol Ann type story, you don't react that you just went through your psych clerkship and it's time to get some help, right? This is a imaginary friend until proven otherwise. Okay, she is 5. Okay.
I think before, like, the weird stuff started happening with the parent moving, they noticed that she was experiencing like some type of odd behavior. She would just stare at the blank TV screen even though it wasn't showing anything. It's like, oh, it's gonna hurt your eyes, and then she moves the channel and just keep staring at it. So that's what I would classify as.
So you're anticipating that when you do reach out to the family,
Yeah.
the collateral report you're going to get is not going to reassure you that they're seeing things that are concerning to them. So this is going to probably do a little bit of an about face, where now you might point the family towards resources that can address what they identify to be problem behavior. Even if the parents don't tell you that they have lost their child, but they are hearing her from what appears to be a portal in the closet, even if that doesn't exist. The staring at the TV for minutes at a time itself might be concerning, right? So what would be the differential diagnosis there? Yeah, I think it would start with seizures. All right, so, and that would fit perfectly with regard to our current case formulation in as much as that medical conditions, neurological conditions such as epilepsy, seizure disorder must be evaluated first and ruled out before we continue the discussion about Poltergeist being a fictional case study of a mental disorder. EEG comes back negative. So I want to reassure you, I'm not going to try to trick anybody here, so it's time to continue this conversation. Does anybody here have any difficulty with this idea that the parents are likely to disclose to us that they are concerned about things that are going on in the house, seeming to be focused on their youngest daughter, right? That's likely to happen, right? We don't think that mom or dad are going to come and give us a story different from what we ourselves saw. What are some other considerations here?
I think from more of like a cynic point of view, you could look at the whole movie as like a case study of child neglect secondary to substance abuse, possibly.
Mm-hmm. Why child neglect?
Just it seems like there are various like aspects throughout the story that kind of hinted at it. Mainly, kind of when when Carol Ann's canary died in the beginning, and they open up the box, the cigar box wrapper or whatever that the canary was placed in. She said that Tweety doesn't like that smell. And a lot of times kids can kind of say that their imaginary friends or pets or something don't like something when they in fact don't like that. So from that you can kind of get a sense that possibly she's been exposed to smoke, as well as I think his name was Robbie. He would like run into his parents' room while they were smoking after his father clearly had rolled a joint or something like that. So from that point of view, as well as there's another comment made by the mom where she was like, oh, what if Carol Ann kind of walked into the pool before we put water in? And that comment kind of, there's two sides to that, because, whether there's water in there or not, there's still going to be a problem if she sleepwalks into the pool. So I think from like that point of view, you can kind of take the whole story like an episode of child neglect as a result of that.
Is there another story in which there is perhaps an imaginary friend with regard to a little girl focused on her bedroom, specifically a door in her bedroom that has the same type of theme?
Sure.
What do you got? Huh?
Monsters.
Monsters, Inc., right? We could actually go with another Disney film there. And one that we just previously discussed, which was Coraline. Right, so we see this reoccurring theme. Now, this shouldn't surprise anybody. I mean, this is a trope, right? Reoccurring themes in film are called tropes. Reoccurring themes with regard to human behavior are called archetypes. And they're one and the same. It really depends on whether or not you want to use in vitro type of stimulus, the film, versus in vivo, real life encounters, whether it's a trope versus an archetype. Right? But again, we're talking about Jungian psychology here. And this is a trope. This is an archetype where we see this parental neglect, like the good father, the good mother, and then disclosed to be not so much. Right? And it is true. They're abusing cannabis, and there might be a form of neglect here, and the children are picking up on this. But there might also be more than neglect. We're rightfully so, choosing to view this film, the occurrences around this family's house, through the perspective of Carol Ann. That's perfectly appropriate. We may want to reconsider and perhaps view this through the eyes of the parents. And if that is the case, what might be going on? Yeah, I mean, if you look closely at this movie, there really is little going on prior to that scene where Robbie runs into to his parents' room. And then since that point, all proverbial heck breaks loose. And why isn't this then, that is the movie Poltergeist, a fictional case study of cannabis-induced psychosis? And it very well could be. Right? Depends on which perspective you choose to take. Of course, there's a third perspective too. There's many more perspectives, but the opposite perspective than either of those two would be that this is a supernatural horror movie. It's one of the last haunted house movies ever made, right? So, and that's something you'll have to choose as well in terms of which perspective you're going to interpret Poltergeist from, right? Quickly with regard to cannabis. We briefly referred to the withdrawal state and the Seinfeld episode, The Abstinence. In this case, we're looking at an intoxication state, and like many drugs, the intoxication state may include perceptual disturbances, and certainly that might be playing out here. Cannabis intoxication, again, is going to, like most drugs, have a behavioral as well as a physiologic intoxication state. The behavioral has everything to do with panic and paranoia, which I think are readily identifiable in this film. What are the physiologic signs of acute cannabis intoxication? So conjunctival injection is the one that most commonly comes up on exams. Any conjunctivitis on a psych shelf is going to be cannabis intoxication until proven otherwise. So absolutely conjunctival injection. What else?
Dry mouth.
Dry mouth, very common. Cotton mouth, right?
Increased appetite?
and the munchies, increased appetite. Those are the big three. Right? Those are the big three. Again, acute cannabis intoxication.
I have a question. With respect to cannabis intoxication or cannabis abuse, could you touch on if and how delusions come into play?
So for abuse slash cannabis use disorder, certainly that's a lifetime illness. It's a chronic illness within which an individual may present with cannabis intoxication. Again, behavioral as well as physiologic signs. In either case, there's a qualifier that says with perceptual disturbances. So in addition to the paranoia, the individual may actually hear or see things that are not there, right? So those are the perceptual disturbances, the hallucinations, right? Certainly auditory are more prevalent than visual. However, visual hallucinations, working the statement backwards, visual hallucinations do occur more commonly in drug-induced perceptual disturbances versus those that are not drug-induced. That makes sense, right? Now, I mean, the other way you could work this, again, this is going to be presented linearly, but it is in human behavior very often the case, right? An individual may be paranoid. That is, they may have this deficit in thought content called a delusion. And within that delusion, there are 5 themes, one of which is paranoia slash persecutory. Okay? So, a couple of quick questions. Deficit in thought content, delusion. Can you give me other examples of such deficits? Sorry? Perseveration. Perseveration, that's really not a deficit in thought content. That's more of a thought process.
Maybe illusions?
Illusions, I'll give you illusions, yeah. Again, the DSM and the mental status exam will usually put that under perceptual disturbances, right? Differentiating the illusion from the hallucination has everything to do with what cues the perceptual disturbance. If something environmentally cues it, it's an illusion. If not, it's a hallucination. So they're more perceptual disturbances, but I'll give you half one. So yes, so for thought content, there are 2 subheadings. One in the textbook, is often referred to as quote unquote killer endings, or KE, because we have to make it part of the acronym for the mental status exam, ABC stamp liquor, right? So killer endings, yes. Under Roman numeral 1, thought content, capital letter A, killer endings. Capital letter B are themes. Okay, themes, of which delusions are one. What are some others? Well, we're going to get to that in a second. We're going to get to that in a second. Themes. Okay, again, we're working this, looking at this flow chart. ABC stamp liquor. We're in the T for thought. And more specifically, we're at the T of that acronym, thought content. Capital letter A, killer endings, itself part of the acronym ABC stamp liquor, so we're going to kind of duplicate the process. Capital letter B, themes. Themes are deficits in thought content, the mildest form of which are referred to as overvalued ideas. Okay. By definition, and this is arbitrary, the overvalued idea is not only the mildest form, but as such will not be clinically significant. And that differentiates the overvalued idea from all of the other different types of deficits we're about to discuss. The most severe of which is the delusion. Now sorry?
I was going to say, is rumination in between those 2?
Yep. There are several, 2 or 3 that we usually talk about, intermediate forms that connect the overvalued idea, not clinically significant, to the delusion, the most severe example. One is a rumination, another is an obsession, and then yet another is a preoccupation. And for all intents and purposes, those terms are really interchangeable. Okay? In a clinical context, there are differences, but for us, they are really interchangeable. Just identify them as intermediate forms of thought or deficit in thought content. Themes. What differentiates the delusion from all of the above is that it is, number one, fixed, meaning that when the individual is presented evidence to the contrary, it remains the same. People do not change their mind. And of course, the other criteria that defines the delusion is that it is not reality-based. So it's not reality-based and fixed, despite having been presented evidence to the contrary, defining the delusion. The delusion has 5 themes. The 5 themes of delusion follow the acronym JPEGs. Individuals who have fixed and false beliefs may have those of the variety of jealous, persecutory or paranoid, erotomanic, grandiose, and somatic. So those are the 5 different types of delusions one may have, and therefore there are 5 different subtypes of delusional disorder if that were the single best diagnosis. What you could then envision is that an individual who graduates from the overvalued idea through an intermediate form to ultimately a delusion has worsening insight. Again, the total lack of insight for the delusion is evidenced through their not changing their mind. That is, that they remain fixed despite that evidence of the contrary. No insight. If something were to happen and insight worsened even beyond that, the individual may reach a state, a mental state, where they no longer even identify the thought as a product of their own mind. And they experience it as coming from outside of their head, and that is the auditory hallucination. So that is the very long and drawn-out answer to your question. How can that happen in the context of really any mental disorder, but with regard to your question specifically, cannabis use? Right? Cannabis will not only hit the ventral tegmental area with regard to that robust increase of dopamine in terms of the addicting behavior itself, but also other changes in the chemical messengers in the central nervous system, reducing insight, resulting in paranoia, which may be happening in this film, if you choose to view it from the perspective of the parents. What else?
What about like a kind of like a delirium picture? I mean, it's like a brand new community from what I'm saying, like a real estate developer, like especially like given that they're all kind of like into this belief that like the house is haunted. Maybe there's like something wrong with the house, like a poisoning or something, like from the construction. It's causing them to have like an altered mental status or a medical like encephalopathy or something like that.
So it's interesting because that's another theme of Coraline, albeit from almost the opposite perspective. Coraline was an old house that students raised the concern might contain lead-based paint, and it may be the etiology of what is happening on Coraline, rule out delirium. You're coming from the completely opposite perspective, that it's a new development. We have no idea what to expect, especially when it's revealed that the developers cut corners, right? And that's the reveal at the end for the supernatural horror fans. Wow, this is all due to the developers cutting corners, right? They didn't move the bodies. They only moved the headstones. Right? But from a clinician's perspective, blaming or focusing on the developers gives us the possible etiology that there might be something going on in this home exposure that itself resulted in delirium. So that's a possibility. Yeah. Other thoughts? By the way, we mentioned these terms. It's worthwhile to explain them, define them. Delirium. DSM-4, the 3 C's. right? The 3 C's that define delirium. Actually, in the DSM-4, there's 4 C's. The 4 C's of delirium included cognition, deficit in, consciousness, deficit in, the course, acute in onset and fluctuating, and then the cause. Always due to a medical condition and/or the direct physiologic effects of a substance. The DSM-5 actually combined the first 2 C's. And they just say deficits in cognition. They really took the focus off of the consciousness. So there's got to be at least 2 deficits in cognition. One could be consciousness, aka orientation. It doesn't have to be. So it kind of took the emphasis off it. But all the other criteria remain the same. All right, I posted on Instagram last week that 4th and final C, the cause, being either I Heart Lady Macbeth or I Hate Coraline. Whatever one works for you. Both were posted on Instagram last week. And again, they may be influential with regard to understanding what's going on in Poltergeist as well. Other thoughts here?
I thought it was really interesting how the son Robbie was really afraid in the beginning scenes, really afraid of his window and the trees and the shadows it would make. And I thought it was also interesting that he slept with his baseball cap on, a way to help him shield against this type of horror that he's seeing. I would classify it as kind of like a paranoia.
It could be. Again, given his age, we'd have to tease that is paranoia from magical thinking that might be well within reason with regard to being developmentally appropriate. Right. So, I mean, some kids, and Stephen King does a real good job explaining this in It, where if you're of a child's imagination, and if you can actually think of and create, ghosts and demons, then you could also create the weaponry to kill them, right? And he actually goes into like a 2-page explanation of this, the mind of a child, which if you've read It, you understand that once these 7 kids grow up, and 6 of them being back in Derry to battle this interdimensional predator, you understand that the loss of that childhood imagination, when the demon persists, but you now don't have the imagination to actually create or conjure the weaponry, boy, are you in trouble. And that's the entire second part of that novel, right? So maybe Robbie in Poltergeist is wearing that hat to gain the magic that it brings. And why might this not be developmentally appropriate? Might be. However, I tend to agree with you, but there's something else in this movie that I think tips the scale, so to speak, towards your opinion. Any idea what that is? Anybody here horror fans? I got one sheepish. So nobody's getting honors for the course. That's right. not everybody can get honors in their clerkship. That's right. So from this film's perspective, there's another major scene in this movie pertaining to Robbie. What is that?
The glass breaking when he's drinking.
Nope, I think you alluded to it before.
Cloud yet, or the tree?
Yeah, that nobody's going to forget that tree coming and grabbing this child. Now again, if Robbie presented, of course, in the care of his mother and father to a clinic appointment with you, and the chief complaint was that I was swept out of my bedroom by a tree, I would hope, as clinicians, you don't think that their house is haunted. It may very well be that it turns out as such, but as a clinician, a practicing doctor, your mind must stay with regard to the DSM. And along those lines, you're probably thinking of now a differential diagnosis, some of which we've already discussed. But your background in horror may help you here as a clinician, because there is a similar scene in another horror movie. No, nobody's seen the Evil Dead 2? Actually, the Evil Dead. No, Sam Raimi? Well, I mean, there's an iconic scene in which there is a killer tree. Actually, Joss Whedon, or Joss Whedon, in 2012, The Cabin in the Woods, identifies it as the angry molesting tree, because it actually does rape somebody in the film. Right? Very similar looking tree. And if we borrow the dialogue from the Evil Dead franchise and we apply it to Poltergeist, we've got a problem. And as a clinician, we might now have a differential as to why Robbie's telling these stories. And it builds on what you previously said, that there might be some form of neglect here. Matter of fact, there may be something beyond neglect. Right? And that's something to consider here. Angry molesting tree appears in Poltergeist, albeit years before The Evil Dead. So that's a consideration here as well. Other thoughts?
I feel like maybe you could explain a lot of what happens if you're looking at it from the standpoint of like, I don't believe what they're telling us by illusions. I feel like the structural development of the house, you could explain away a lot of things like the shifting of the chair, maybe the house was built on an incline or something like that. All the electricity problems that they have pertaining to maybe like the flashing lights of the TV and things of that nature. So maybe from that perspective, that these could all be like real things that are allusions to these people as a result of their substance use.
Mm-hmm. Yeah, sure. I mean, with those defects that ironically the husband would have known of. And actually, I'm sorry, I take that back. That he perhaps should have known of but didn't. Yeah, under the influence, they could be experienced, especially hallucinogen. They could be experienced much differently. And if you're going to maintain the perspective of viewing this film through the eyes of the parents, yeah. So again, it ties into the main theme, major reveal in this plot, right? And that there are significant imperfections in this house, to say the least. Right? The developer gone bad.
I don't think it's super likely, but to build on Gustav's earlier point, if Rob's a little bit older, I think you could make the case that he's kind of, initially there's kind of like more subtle perceptual disturbances, like with the tree that he has a big sense of paranoia about it, and they kind of simply a case of what's it called, clinical hyperpsychosis, and that kind of starts off with this sense of paranoia, this sense of fear, and these perceptual disturbances, and then it kind of progresses to hallucinations and more kind of psychotic features later on in the film. So I think that could be another angle as well.
And with regard to Robbie's psychosis, why would you be concerned about his age not fitting that model?
I could be just because I've seen all these for like in teenage years, but it could be. I feel like it's more a huge thing because obviously we don't see schizophrenia until usually the second decade, but I guess it could be as early as that, I suppose.
Yeah, I mean, especially cannabis use, being a confounding factor.
Yeah.
And it obviously being in the home, and I think what we've picked up on the kids knowing about it, that would be a concern.
I'm not too familiar with the numbers, so I guess I should pose this as a question, but the link between that specific substance abuse and schizophrenia, has that been specifically established and then established in patients of younger ages? Has that been done before, or?
Yeah, so I think that there's a lot of research on it. It's a hot topic now. There's, I think, observational studies that that teenage boys who use cannabis, they've been found to, I think, have an increase in schizophrenia. I think on CT imaging, they found to have they have increased ventricle size. There's no kind of causal pathophysical link to my knowledge, but there is an observational finding that there's increased incidence. Is that correct?
That's right, yeah.
So then the idea being that maybe contact high from being around the smoke exposure could predispose him to
developing?
So that I know less about. We know that secondhand smoke with regard to cigarettes is a real thing. And we've seen, the current literature actually has published incidents of lung cancer and other diseases as a result of secondhand smoke. I have not seen that literature with regard to cannabis. I haven't. It doesn't mean it doesn't exist. I just haven't seen it. Certainly not near as many publications or as robust in the literature as tobacco. Other thoughts here? By the way, just building on this adult perspective, and is this entire movie nothing more than cannabis-induced psychosis or cannabis-induced psychotic disorder? When you adopt that kind of view, it's worthwhile either reviewing the film or even rewatching it, looking specifically for other evidence or further evidence of cannabis use disorder and/or cannabis intoxication. We mentioned everything here. Is there any evidence in this movie with regard to the DSM criteria you told me that defines cannabis intoxication? I don't expect you, of all things, it is the most common one that comes up on exams. I do not expect you to remember the eyes and the conjunctiva of these characters. I mean, unfortunately not. Any evidence of dry mouth or the munchies?
I feel like the munchies might come up. There was this scene when they called in that parapsychology team to come in, and two of the gentlemen are talking, and one of them excuses himself to go get some food, and he starts snacking in the kitchen, and then has that weird perceptual disturbance with the meat. So that could have been an example. As well as they have like a nice family breakfast one morning, and there's a lot of food on that table. This looks good. So.
Yeah, so I'm gonna give them a mulligan on the breakfast. I like big family breakfast, so I like that. Painting that picture is a must. But yeah, it's one thing to sit back and say that the parapsychologist scene with what happens with him is in a vacuum. You'd be right. I mean, but the other way to view this, or the other way to interpret this, is that that's a pretty, I want to fall short of saying iconic. It's a pretty memorable scene, and scenes that are memorable like that and are qualifiably memorable. Maybe that's a way to symbolically quantify things, right? Make it memorable, and therefore make it part of your diagnosis. And it's hard to dismiss that as not being memorable, right? So I'm going to buy that one. Okay.
Is there a link between schizotypal personality disorder and substance abuse?
So I think there is,
Okay.
and not nearly as established as schizophrenia and substance abuse, but there is. It's a much weaker link. Yeah. Anybody here? We may as well, again, let's discuss these terms. We're discussing now the type A personalities, that is, character traits that actually predispose to the development of schizophrenia and schizoaffective disorder. These personality traits tend to cluster or constellate so reliably that we apply diagnostic labels to them, so that when we say schizotypal, we know what we're talking about. We know what the person's trying to describe. Similarly, paranoid personality as well as the schizoid personality, right? So when we're discussing the personality disorders, the DSM, the American Psychiatric Association, will put them into three groups called clusters, because not only do these signs and symptoms constellate, therefore lending to a diagnostic label, but those diagnostic labels also tend to share common characteristics as well. Hence, they're put in these groups called clusters. It's a nice way to learn them. In my brief history with medical student education, it's often difficult to remember the personality disorders by learning them that way. So another thing we can do, and it's really two things, but one other thing you can consider, especially as a clinical pearl, is to just throw all of those personality disorders just back into a bowl and pick them out and put them into one of two groups. One group that adheres to a cardinal feature, and then one group that doesn't. And when you look at the paranoid personality, for example, it's one thing to identify that it's a cluster A personality, and you'd be right. But it's another thing to recognize that this individual is defined through a pervasiveness of suspiciousness of others. And once you understand that, the DSM criteria then just morph into examples of that cardinal rule. Much easier to learn. Okay? Schizoid, loner. Schizotypal, bizarre, magical thinking. So these three cluster A's also are in that proverbial new column that are defined through a cardinal feature. Much easier then to recognize the DSM criteria inasmuch as they are but examples of that cardinal feature. Now, having said that, anybody in this film demonstrate behavior consistent with any of the cluster A personalities?
The reason why I asked the question earlier was because the parapsychology team, I didn't know if maybe you could think that they could fall under the schizotypal branch, and then the link to substance disorders, we've seen the head professor sharing like drinks with the mom of the house, so they could have been sharing cannabis as well while they're there.
Interesting. Yeah, again, certainly there are aspects of the parapsychologist in this film that are consistent with the schizotypal personality. Whether or not those characteristics are clinically significant, I think should be part of the discussion. But that in combination with potential drug use can manifest in the actual signs and symptoms that make the plot of Poltergeist. That's an interest. So you're saying that maybe not as much, or in addition to the perspective of the parents, this film may be told through the perspective of the parapsychologists.
I think that's
Right.
an angle of that.
Interesting.
I think also the clairvoyant Tangina, I think she might be experiencing some cluster A, I would guess.
I was going to include her in that group, the leader of that group, really.
Yeah.
And again, there's multiple reasons why people profess to be clairvoyant. And I do want people to have open minds. One of those reasons may be, in fact, that they are clairvoyant, right? You have to keep an open mind. But there are other reasons to consider too, right? And when we talk about some other reasons, I think the cluster A personalities are in that discussion. All right, so we're good on time. Any other final thoughts with regard to Poltergeist? You guys like the movie? A little bit. All right, we'll sign off here. We'll stop here. You guys can grab some lunch, and we'll come back and discuss Pinocchio with a little bit of Pet Cemetery over Periscope. All right, have a great lunch, guys.